a moment.
This conference is no longer being recorded. This conference will now be recorded.
There we go. We are ready to begin, Ms. Montgomery.
All right. Thank you so much, Benton. And Benton, you can call me Betty. Folks, we welcome. Good morning. In this sunshiny, snowy day, Compliance Committee has begun. We have a very short time frame, so I'm going to move rather quickly through a couple of things because we have a lot to talk about at the end of the committee. Have you all had a chance to read the minutes? And if so, we would entertain a motion to adopt the minutes.
Move to approve.
It's been moved by Dr. Schottenstein, second by Robert. And all in favor? Aye.
Aye.
Opposed? Same sign. The minutes have been approved. We're moving now into the treatment provider applications. You have a memo from Brandy in your documents. We have 5 applications for approval as either a treatment provider or a one-bite provider, or sometimes doing both. We have, Brandy, did you have some things you wanted to say about this?
Nothing other than what was in the memo.
Okay. Any questions or comments about the recommendations to approve these applications? Any comments, concerns? If so, we have Benton. Brandy and I talked about this last night. Should we recommend have a motion to recommend on each individually with individual votes, or can we take it collectively?
You can take it collectively.
Okay, so we have a motion to recommend the UF Health Florida Recovery Center to be approved as one bite. We have Parkdale Center, who seeks to be both a treatment provider and a one bite provider. We have Talbot Recovery Campus, which seeks to be a one bite. Cleveland Clinic Alcohol and Drug Recovery Center, which seeks to be a treatment provider. And finally, we have MAR Addiction Treatment Centers, which seek to be treatment provider. Is there a motion to recommend that these be approved?
Move to recommend.
Second, Giacalone.
Dr. Schottenstein moves to approve. Any recommendation? Any second?
Second,
It's been
Giacalone.
seconded by Ms. All right, Giacalone. All in favor of a motion to recommend these 5 providers to the board? Do we need to have a voice vote? Aye.
Aye.
And anybody opposed? Same sign. It's been moved. It's to recommend these 5 health providers to the board, and it has been approved. We then go into the OPHP evaluations. As you recall, if you look through your minutes last time, we talked about the availability. We talked about broad things like what are our what are we really doing, and how successful are they? What we're doing? And by the way, is money getting in the way of us being able to, 1, treat, or 2, allow people to comply to board orders or board referrals? And as a result of that, Director Luca and I and Brandy and the director of OPHP had a chance to have a meeting for several hours, and I know staff have had a series of conversations and meetings to try to take a look at responding to the cost of evaluation. If new policies need to be adopted, is there another way to approach it? So I'm going to turn this over to Brandy. Brandy, do you want to give us sort of a thumbnail of your memo?
Yes, thanks, Betty. So as we've been discussing this matter since the last board meeting, like Betty said, Stephanie and I and Kelly Long from OPHP have been really talking about what we need to do to make sure that the program is structured for the success of the licensees. And one of the issues that had been brought up was the cost of the evaluations, specifically to the respiratory care providers and then to the other allieds. And one thing that the committee had asked for us to talk with Kelly about a little more and get a little more information was specific to the other allieds with problems affording those 72-hour evaluations, and really what was most clinically appropriate for all of our licensees. So I laid that out in the memo where I talked about the average cost of the evaluations, and we looked at some numbers. We used statistics that were provided by OPHP to identify the number of individuals referred by the board for evaluations for OneBite, which was a total of 96 since program inception. Of those 96, approximately 63% either did not follow through with the evaluation because they declined, or they weren't given a diagnosis. So that breaks down into 61 total individuals who had either declined or not gotten a diagnosis. So we thought that was a large proportion, and how can we work together to see what a better outcome would be for getting those individuals into the evaluations they needed. So what Kelly and Stephanie and I had discussed was breaking the licensees into the two clusters. Cluster A, which were individuals that Kelly with OPHP felt needed that clinical part of a 72-hour evaluation, and that could financially support that evaluation. And then Cluster B was those subset of a lot of allieds that were citing financial concerns that clinically may not need that 72-hour evaluation, but still need an evaluation. So that's where the Cluster A and Cluster B comes from. And then I reached out in discussing this to Kim to discuss kind of legally what would need to happen in order to make any changes if the committee felt that these clusters were appropriate. And those the legal discussion that we had was outlined. So when we looked at it as a whole, we really thought that this would be a good recommendation for all of our licensees.
Did you have a discussion with Randy? I know we did, but about the quality of the evaluation, the differences between a 72-hour evaluation and the 24-hour evaluation? Andy?
Yes, we did talk about that, and they're both very clinically appropriate evaluations, but the thought with OPHP having such a specialty and working with physicians, they really saw clinically that the physicians in that group in that cluster responded better to the 72-hour evaluation because it gave 3 days of full-on discussions, an ability for those individuals to take some time to absorb everything that was going on. Whereas in the Cluster B, also a very clinically appropriate evaluation, but the individuals in that subset may benefit from that outpatient evaluation better than the other cluster. So they did discuss clinical appropriateness for each one of those based on their outcomes and what they've seen and their years of dealing with professionals.
Doctors who are listening here, one of the, and I think all of you might agree with this or disagree, I guess, but they found that the doctors, educated as they are confronted. It's a harder sell to finally get those professionals to recognize that it's an issue that they're dealing with, as opposed to just that, look, you're making too much of it, which is interesting. And any comments or concerns by the committee about this? Yes, Dr. Schottenstein.
Hi, I guess I would say that it doesn't surprise me, right, that physicians might be a little more entrenched in that regard. I would also say that I substantially, believe that the changes that we're contemplating are appropriate. We've always had that carve out for the massage therapists. And so when the issue came up before with the respiratory care professionals, it only seemed reasonable to sort of use it as an opportunity to sort of rethink whether or not we would want to have additional carve outs, for our other licensees. And so this feels reasonable to me. I think that it keeps the physicians and the PAs in the cluster A, and also the anesthesiology assistants, to Dr. Caccarella's earlier concern, and the other specialties, I think, could be well served with the outpatient assessment.
Thank you, Dr. Schottenstein. Yes, Dr. Bechtel.
Yes, I think the recommendations are very appropriate, and I think these are challenging times for healthcare with COVID-19 and the stress it's created on our healthcare personnel, on practices. I think we're, again, facing unprecedented times, and we don't want to have roadblocks or barriers as far as cost of reaching out and seeking help. And I think this is a really appropriate time to move forward, and I think the recommendations are very appropriate.
Any other? Yes, Mr. Giacalone.
Darcy, just two questions. Well, one question, really. Board of Nursing, Board of Pharmacy, where are they on this? Because my concern is whatever we do is probably going to have ripple effects there.
Good question.
Yeah, that's something we didn't discuss. We tried to narrow our focus just to our licensees, but I can get that information and bring it back to.
Okay. It's not a killer. I'm just curious.
Okay.
Second question to the group. What if we have a respondent who gave up their license because of economic reasons and then comes back because we've changed things? Are we going to get them back in? Because that's going to happen.
I'm sorry. What? Could you repeat that again, Robert?
My question is, in category B, I'm not opposed to this, but it's more a question to the group. If we have someone who gave up their license in the past, right, because they couldn't afford it, they come back to us now because they've surrendered the license. I mean, aren't we going to be almost obligated to let them re-enter?
If it was a non-permanent revocation, then that seems only fair.
Okay,
Yeah.
I just want to make, I think that makes sense because I mean, I don't want to be retroactive, but it seems unfair that from a timing standpoint, they missed the window. Okay, that's fair.
But they still have to be evaluated. So
Yeah.
Well, sure. But I mean, if it's a straight up situation, as if they came, it happened before and it happened now, we wouldn't prohibit them, right?
Absolutely not. Yeah, I mean, especially if the reason they gave up their license was for financial reasons, we would, I think, encourage them to circle back with us.
Like
Absolutely.
that too.
So that does, I guess, Mr. Giacalone does bring up this. Do we have an affirmative duty to alert folks, or do we just, personally, I'm not sure we do, but I suppose it's a question that should, Stephanie, what do you say?
So I would say, in fairness, I think particularly over the last, let's say, year to 18 months, given what's been happening with the pandemic and the increase that we've seen in One Bite participants from the allied professionals, I think it's just a sense of fairness that we would circle back with them to let them know of the new, when this rule becomes effective. If they've walked away from their license because they couldn't afford it, and we may never know, they may have said they couldn't afford it but didn't want to do it. I think we just presume that it was a cost issue and we let people know about the new rule. And then
You can recover it? You can recover that information?
Sure.
Okay. I have a question. I'm sorry, go ahead.
Yeah, Betty, I've already started making a list of individuals who have either refused or because of cost. So we've got that information tracked already.
Of course you have. Thank you. That's very good, Brandy.
you have, we do know that legally we can do it, except we'll have to have some rule changes. What's that process? How long will that process take to have us be able to start offering this?
It's hard to predict. It's going to have to follow the normal process that, we'll have to go through CSI and JCAR. So it's hard to predict. We can have some draft rules to you next time. The other thing that I wanted to clarify is, we would be doing this across the board. So for one bite people and for non-one bite people. And the other thing to keep in mind, and this is in the rule changes that you have in your memo, the treatment for massage therapists is an intensive outpatient treatment instead of residential or inpatient. For one bite, there's flexibility. The treatment is determined by the provider, but we would propose that if you have an outpatient evaluation for the category B individuals, that you would have the intensive outpatient treatment available to them too, that the two things would go together, and so that you have category B all being the same, with an outpatient evaluation and intensive outpatient available for their treatment. And for category A, they would have the 72-hour evaluation and the residential or inpatient treatment.
How much, Kim, does that add to the cost of the evaluation?
It doesn't have anything to do with the evaluation. It's if they're found to be impaired, it's the treatment.
Yeah, no, I'm sorry, I misspoke. But how much does that add? We're here to try to reduce the cost.
It would reduce their cost. It would reduce their cost, because now the individuals in that you're going to be adding to category B, they have to have, if it's not one bite, so if it's, the board sending them, they have to have residential treatment for a minimum of 28 days. Massage therapists don't have to have that.
I appreciate that. I'm just asking this question. We know that we reduced the cost approximately $800 for those who are doing the one-day evaluation. When you do then the intensive outpatient matters, how much does that generally then add to $800 plus? Do we know the costs? Do we have a sense?
I think we can get that information.
Okay, great. And
it would result in a savings for the individuals in category B.
It's still significant. Brandy,
Yes. Mm-hmm.
Okay. And then Brandy, your last bullet point in your memo says the behavioral health assessment tool could be used as a pre-evaluation prior to decision being made for a license. Could you expand on that a little bit? I know we talked about it, but perhaps the board would want to hear, or the committee would want to hear about that a bit.
Yes. So in discussion of solving, problems which were barriers for licensees, we also were looking at the individuals who were evaluated, who were not given a diagnosis. And what we had found was a number of those individuals were licensees who had reported arrests for things like DUI on their renewals. And so OPHP offers this behavioral health assessment. It's a tool that can be utilized for situations where we have referrals for individuals that may have been in that situation of reporting an arrest on a renewal and having that DUI. It gives them an ability to do a pre-assessment prior to sending someone for a full-on evaluation. So they can already gain some information. Like it says, OPHP provided a nice description of what they can do. they can do a clinical interview and get a bunch of information from collateral resources in order to kind of make a predetermination of if this individual is going to need a full-on evaluation. And it kind of takes away that.
So if that individual happened to fall, it was a physician, we would normally say you have to do a full on. But I think we're going to have some more conversation about that, because if they do it as a pre-evaluation, we say, look, this is not, we have no indication that they're an issue. Do we then, because they fall into the category requiring 72 hours, do we then say, what are our protocols in terms of what do we do with that? And do we want PHP to do that? Those are some of the issues. The other issues are, do we want to expand? Do we want to use some of the services that OPHP has for us to help us in terms of other needs that we have as a board? And Brandy, you and staff will be looking at that to come back with us about other conversations, expanding our capacities to be of service to this group of people. One of which is discussing, do we want a law change that says, look, if you're a licensee and you are arrested, that you have to immediately report it. So it gives us a chance, instead of waiting until re-upping, to begin the process of looking, do we have a problem here? So if you can get back to us on that, would be greatly appreciated.
Yes.
Brandy has done a lot of work in this area, as has staff, and thank you so much. I think you've done a great job thus far, and we'll look forward to more information from you. If there's nothing else to do we want to make a recommendation to agree with, do we want to vote on a recommendation to go forward, or do we need to, can we just proceed? Stephanie, what's your brother's?
I think Dr. Schottenstein has something.
Oh, I'm sorry, Dr. Schottenstein. Thank you very much, Harish.
Yeah, thank you so much. And yeah, you're very kind. And I'll be quick because I know we're running short on time. But just I wanted to sort of remind us that in terms of that issue of us not being informed about when there's a legal matter until a licensee renews on a license, there is that wrap back program. And I know, Stephanie, we've talked about that before, where we can potentially sign up for that program and be, notified in a timely manner when one of our licensees gets into some trouble. And so, would be glad to, just sort of keep that in mind as an option for us. Thanks.
Dr. Schottenstein, I'm not familiar with that, but Brandy, if you can make the committee aware of that and the options, and it may be, we may want to do both suspenders and belt on that and require it of the licensee as well as double check. So you can get back to us on that. Do we need any formal move on this committee to make a recommendation that we proceed, then, or do we, at this point, where are we? Stephanie, do you need anything formal from us?
I think we can draft the rules and bring the rule draft back to you.
Okay, great. If there's no other conversation on this, we'll move on to our compliance statistics follow-up. We continue to discuss the quality of our tracking and the necessity of some of our board and agreement orders. We're getting this data will help us in terms of staffing and as well as quality of compliance. If you want to turn to the more colorful memo that Brandy's put together, we'd greatly appreciate it. Thank you, Brandy. The floor is yours again.
Thank you. So just as a continuation, I'll just be brief since we're running short on time. From our previous conversation of what does the board want to see as far as data coming from the compliance department. We're starting to collect information to enhance the program that we already have. We have a good program. We have a good staff member, and we have a lot of motivation to continue to improve. And one way that we are going to make improvements is by looking at some of the data, looking at what we're doing on a regular basis, seeing the different types of licensees we have coming into the program. So I don't want to get too much into the breakdown because I know you guys all have this in front of you. So I just provided just some basic statistics reports, just letting you all know who we have on probation and kind of a snapshot of what that looks like. I didn't go specifically into One Bite or to confidential monitoring because of concerns with being able to completely de-identify information. However, I think we can provide quarterly updates that would give us a larger sampling of data, which would allow us to de-identify further. So that'll be something we'll be presenting here in the coming months. But really specifically into the January compliance statistics reports, where you guys can see the percentage of probationers that we have by types of agreements and board orders, the individuals we have by license types, as well as...
Can I stop you at that one?
Yep.
I don't understand. When you look at this, you have physician assistant. The top blue line, that's 7. Who is that? Because you only have a designation for physician assistant on 8.
My apologies. It must have compressed it when I put the memo together. I can provide you all with an update on that. It's a breakdown of all of them. Let me pull
Is number 7 a physician? Is 7 a physician assistant, or is that somebody else? Some other kind of?
Yeah, it got compressed. So let me get back to you on that specific number.
If I only knew what compressed meant, it would help.
It means it shrunk. It means it shrunk and it took out that top line. So I can get you an update on that one. Yeah, it shrunk it. But it just gives you an overall, it tells you that most of the individuals we're supervising are physicians.
It's shrunk. All right. Well, listen, thanks so much, Brandy, and your staff. You've done a great job. And it's great to be able to have data to back up, to make our decision-making more solid. Finally, in the few minutes we have left, we have a letter from the Medical Associations Coalition, and I think you probably have all had a chance to review that letter. And with regards to concerns about questions we're asking on our application, language we're using, public disclosure of personal health information, concerns about confidential monitoring, etc. I think you've read those all. Generally, Kim, can I go to you first about the question about our application? I know you did a very thorough, as we had a chance to look at. I think it was you, Kim, or somebody did an evaluation.
Yeah, it was one of my staff attorneys. Yes.
Yeah.
Yes.
Yes. You want to go forward and talk about that a little bit?
I'm sorry. I thought there was a question. I'm sorry. I think back in 2015, we had looked at the questions around, impairment and made some adjustments. At that time, we had a 10-year look back. We reduced that to 5, and we modified the questions, and that was a pretty lengthy process that we went through. So what we wanted to do was just look at where we are now with the other states. You can see that a number of states don't ask any type of impairment questions. I guess my overall assessment is, and a number of states have a longer look back. So I think we're still in the middle with a 5-year look back at this point. There are some states that have a shorter look back, 2 years. There's a number of states that ask for current status only, for individuals who are applying. That, I guess I would say we're still in the middle, but there are a number of states that just ask for current or ask for a shorter time period. So if the board can weigh that if you're deciding that you would want to make a change.
I think I'm sorry, Dr. Schottenstein?
Yeah, of course. So sorry, I did not mean to interrupt, but I was going to say, I'm not sure that the middle is really so viable for us long term. I think that the trend is to move toward either a shorter look back or just a question about current status. It looks like, the number of states have moved in that direction. And, I think it would actually be helpful, to have, if someone would be so kind as to provide it, the FSMB position statement on wellness and burnout, because it really very much speaks to these issues that we're contemplating in the MAC letter right now. And so, when I look in that position statement, it looks like the FSMB proposes, keeping the questioning about impairment to current status. And long story short, what they're saying is if a board does feel obligated to go longer back than current, that they try to keep it to 2 years or less. And there's also a statement in that wellness and burnout document, to the effect that, it's important to recognize that court interpretations of the Americans with Disabilities Act, and I'm quoting now, have suggested the state medical boards should focus on current functional impairment rather than a history of diagnosis or treatment of such illness. So, I certainly want to be sensitive to staff. I would not in any way want to pull the rug out from under staff who felt like it was important that we, be able to look back. But I do think that we should try to move in the direction of current status as much as staff is comfortable with, to try to sort of get right with the way I see things going.
Dr. Schottenstein, I think that we have much to talk about on this. This is just the first bite of our this conversation. On a personal level, I would have a very difficult time us going to current. I am not necessarily personally persuaded that just because everybody's doing it, we should do it, but it certainly is a point of informing us as to what might be the best practices. And obviously our staff will have to continue and perhaps come back to us as next step, because we haven't really discussed any disclosure questions or whatever yet. And then we will then have to discuss with Stephanie and staff, how do we address this with how do we respond to this letter? Do we do it just by phone call? Do we sit down with them and talk through it? Is it a letter response and that? And it might be a little early to think about that given the conversation, which we still have to flesh out. Are there any other comments or concerns about this? Dr. Safran.
Just as a point of information, the questions on our application have gone through some thought process of revising them. Joe from licensure has presented some changes to the questions, and we had discussed this yesterday in rounds about incorporating some of the concerns of the MAC into these questions, and he was working with Stephanie and staff about revising the questions. So there is a process ongoing about that.
That's great. Thank you so much, Dr. Safran. That's very helpful. And I think this really deserves a fuller discussion at our next meeting, if that's timely and capable of being done because of staff work. But Dr. Schottenstein's comments, as well as the MAC's comments, as well as staff's comments, are certainly critically important for us making some decisions going forward. Yes, Mr. Giacalone.
As long as we're going to look at the FSMB proposal, I think we should call the states that still have the years in place and ask them why or what they've found, why they've kept that position. Because, I'm seeing, the FSMB is one position, right? The states that continue to have a 5-year or forever look back. What's the rationale there? We just reach out to them. Maybe they don't have a rationale. Maybe it's just been etched in stone, but I'd be curious to see if they've had experience and said, well, yeah, we looked at it, but we didn't do this because of this or that, or our experience.
I think that's a good idea. And to the flip side, the ones that have made the changes, what their experience has been since they've made the changes. Just a really quick data point for you. We looked at our renewal applications from 2018, 19, and 20. And on the question on have you been addicted, since your last application for renewal, in 2020, 0.03% answered in the affirmative. I think we know statistically that doesn't really mirror with addiction numbers in society. And so I would say we probably have a question that isn't getting us the right information anyway. And we still need to break down our initial application data to that same effect. We also know that in our historical case review that we did for the Strauss Working Group report, we found as we were looking back at those 1,250 licensees, we found a very high number, a significant number who had OVIs who did not report those to us. And so, some a decade old. And so I think what we really need to, what information are we getting that is meaningful and that we can act upon, right? And I really like Mr. Giacaloni's idea to talk to other states. I think that's how we can learn what's working and what isn't working in other places as well.
Well, that's great. And yes, Dr. Schottenstein.
Forgive me. I was just going to say that's really compelling, Stephanie, about the lack of reporting of the DUI. All the more reason why we'd be right to take another look at the Rat Pack program, and all the more reason why we were right to, timely make those legislative, proposals so that law enforcement, would be right to be in touch with us about situations like that.
Great. Well, listen, if it's all right with you, I think we've gone through our agenda now, and I think we're bumping up against FSMB. I know some of us on this call are on this are now having to be on committee of the next MMIG. So with that, I think we will. I will entertain a motion to recess or to adjourn this committee.
Move to adjourn.
Been moved by Dr. Schottenstein.
Second, Dr. Cockrell.
All in favor? Aye. Same sign.
Aye.
We are adjourned.
This conference is no longer being recorded.
Thank you.
Thank you.